the memory clinic here, and how we might help differentiate from different types of dementias. We'll just give more of an overview. Subsequent talks next week and following weeks, we'll go over each one of these in more detail. Accreditation wise, that is all going to be down in the chat. And then disclosures none for this talk. So I wanted to first kind of start with the most common question I get in the clinic. And part of this is the confusion of terminology is what's the difference between Alzheimer's disease and dementia? So we'll tease that out. How do we currently use biomarkers? How do we think about those in sort of aiding that differentiation? And then really kind of talk a little bit about our role as a memory clinic, specialty clinic, understanding our limitations that we can't see every patient, and we're going to have to start prioritizing referrals based on our current referral load. And so the difference that this is how I describe it to patients and families. Dementia is essentially an umbrella term. It's a syndrome that there's enough cognitive impairment that interferes with daily life. And obviously this is a change, right? That's not explained by other factors like psychiatric disease or otherwise. But Alzheimer's disease is the most common cause, right? So if you think of that umbrella term, Alzheimer's disease is the largest part of that pie, with roughly 60 to 65% of cases of dementia due to Alzheimer's disease. Alzheimer's disease is really a neuropathologic diagnosis or neurobiologic diagnosis when patients are still alive. And it's characterized by amyloid plaques, tau tangles that build up in the brain and that cause these cognitive and behavioral symptoms that cause dementia. It's a progressive brain disease, but there are different stages that we're starting to qualify with. So patients can be, like we'll talk about next week and we talked about last week, can be amyloid positive, amyloid plaques in the brain for 10 to 20 years before they have true symptoms. So that's more classified in a pre-symptomatic stage. And then we have the mild cognitive impairment stage, which we talked about last week, and dementia stage, which we focus more on today's talk. It's also important to note that Alzheimer's disease is not one symptom, right? It's not just short-term memory. There's different phenotypes. So next week, we'll kind of delve into some of these different phenotypes, but the one we classically think of, the most common one, is short-term memory or the amnestic variant. But we have these other visual variants, language variants, and then dysexecutive variants that we'll talk about next week. And so it really kind of depends on where is the pathology in the brain of what patients present with, what they come to see us with as far as their main complaints, and teasing those out. It sometimes requires more questioning than just, are you repeating yourself, or only asking about amnestic symptoms. Here's just the overview slide that kind of talks about, what we typically see. So I actually kept track of numbers the first year I joined KU after coming back from Mayo. And these roughly were consistent with what the literature posts. Obviously, every referral clinic is going to have a little bit of different breakdown of these, but Alzheimer's disease is still by and far and away the most common. Lewy body disease is actually the second most common. You'll hear vascular disease quoted as the second most common, but I will tell you that that's usually from a co-pathology standpoint. It's a common co-pathology cause. And you'll notice very quickly that I can't add up to 100, right? And that's really just because there's overlap with these syndromes. So I mentioned here that in Lewy body disease, there's coexisting Alzheimer's disease in 30 to 40% of cases. And even if you just include amyloid, it's even higher than that. So this is really how we're starting to think about these things. It's not always just Alzheimer's disease, say here in blue. There's overlap of Lewy body disease or vascular disease, right? Usually when brain pathology is building up, it's not just one specific pathology. So co-pathology is the rule. However, we can usually find what the primary etiology is, and we're going to get better with that as we get better biomarkers and imaging tests. So let's do a quick puzzle. This is a 72-year-old that presented to her PCP with cognitive concerns. These all kind of started when her husband passed away 4 years ago, and so very reasonably was thought as sort of grief and everything. The family really just kind of noted some troubles with finding words in conversation, and so those symptoms kind of went on. And then it's really they didn't get too concerned until the past year, where there's been more significant decline. Things were very gradual up until the last year. And now she's really struggling to get words out in conversation. She's losing her train of thought easily. Things like cooking and things that require multiple step commands or multiple step processes, she really can't manage anymore. And there's a lot of anxiety associated with these symptoms too. So it then starts to turn into this vicious cycle. If she can't think of the word, anxiety goes up, and that doesn't help her think of the word. There's no major concerns with just pure short-term memory. But again, her daily tasks are starting to be impaired, especially taking medications and bills being paid on time to where families having to help out. And so, when we think of this, like, if you think of everything as a memory problem, right, you might ask these questions or repeating oneself, maybe missing these bills as part of that, and medications. But it really behooves us to ask maybe a few other questions, especially if the patient and family's concerns is the language, right? So asking some questions about, naming objects, getting the words out that they want to say, right? These are things that the executive ones, so cooking, sequential tasks are important ones. Maybe difficulty planning, like say they need to book a hotel or those types of things, right? These are all things that you can at least expand on your history taking, other than just kind of the memory tests. For her, so very reasonable initial workup, right? Do these reversible causes like we talked about in last week's lecture. We typically recommend B12, TSH, the normal lab studies that you get on yearly evaluations. All those came back normal. There were not really any specific medications that would at least explain some of these cognitive symptoms, or at least that wouldn't be contributing. A sleep study was done, which showed moderate sleep apnea. There was no bed partner to kind of report certain things, but she was having some daytime sleepiness. So a sleep study was done, and she wasn't really interested in treating that, which again is part of maybe a disconnect in how important this can be, but that we see this commonly. Hearing test was normal, so that couldn't at least explain some of these language difficulties. And they did do a MOCA screening test. There's enough concerns to do a screening test, and she scored in an abnormal range. So 20 out of 30 is abnormal. But then you kind of look at where is she missing points. It's more in the language, visual, spatial, more than memory domains. And there's a certain part of the language test that's actually pretty helpful for this specific disorder, which we're going to talk about. Repeating long sentences. So, you have the patient try to repeat back this long sentence, and really struggled with that in this patient. So an MRI scan was ordered to try to find any structural causes, right? And we talked about that. What are the purpose of these MRI scans? Well, we got to rule out any large stroke or even kind of incidental silent strokes that could account for vascular burden on the brain, tumors, right? These are the point of these initial scans. There are quantitative MRI programs out there. Mayo Clinic has one. Banner Health in Arizona has one, and some smaller radiologists use them too. They can pick up on subtle asymmetries between the right and the left half of the brain. However, most radiologists don't use these programs. Most reads are going to be generalized. You have to realize that, and I'm sure many have seen a similar report to this, right? Where mild to moderate white matter hyperintensities, likely reflective of chronic microvascular disease, and generalized atrophy without specific pattern. This is a very common radiology read, or sometimes it'll just even be unremarkable MRI of the brain. One thing to note, if you're going to refer a patient to us and they've had imaging, it's very helpful for us to have the actual images, because I don't always just rely on the radiology read. I want to look at the images myself. So we're usually trying to track these down, but that's just a helpful tip for referrals. It's very helpful to have the actual images. This idea, so this patient was referred to our clinic, which makes a lot of sense in this case. Right now, as a new patient, it's a 10-month wait, so I've taken over as the medical director here, and we're working on a triaging system to try to make sure we meet the needs of the patients that need to be seen sooner than later that don't have an established diagnosis. So we're going to have to really prioritize our referrals going forwards, and that's going to be a long-term fix, but it's very reasonable in this case to refer to us because the diagnosis is uncertain. All the reversible causes have been done. The MRI has been performed. oftentimes what I'm seeing, at least in our referral systems, is there's a family history or there's kind of nondescript memory concerns without a workup being done yet, no imaging being done, or sometimes referrals are just for requesting research studies, and we have a whole research team that reviews research referrals, so that doesn't need to be seen in our clinic to potentially be requested for research. I think part of this is, well, we don't know, so maybe something's going on, and let's see. But in those scenarios, I'd really recommend just getting detailed neuropsych testing, because that's going to give you a comprehensive picture of, is there an objective memory problem? And that actually really helps our research team triage things if they've got cognitive testing, because then we've got studies that are subjective cognitive impairment or mild cognitive impairment or dementia, and we really need that neuropsych testing piece to help triage that. That also helps our clinic triage process as well. And so our current model, right, we're doing this where basically the nurse practitioner and neuropsychologist are seeing the patient. They're getting the detailed testing as part of that process, especially if it hasn't been done previously. If labs were not done or we don't have them, we're trying to request them. And then any neuroimaging that hasn't been done, we're trying to get done. Sometimes we'll do specialized imaging, which we'll talk about, and spinal fluid analysis, which we'll talk about. And then basically they meet back with us as the neurologist with more of a diagnostic visit, so we can focus more on, hey, what do we think the working diagnosis is, and get a plan in place. And so on this patient, detailed neuropsych testing was done, and it was most prominent for deficits in language and executive function. It was labeled as sort of multi-domain impairment with decline in daily functioning tasks, so mild dementia and more of a non-amnestic pattern. And our neuropsychologist, mentioned that this could be consistent with like a temporal lobe dysfunction, right? And so then it kind of helps to understand this, or at least have that in the background of what are we looking for when we look at this neuroimaging, right? So if we pull up, just kind of a map of the brain, we're kind of looking potentially for language within this temporal lobe here. That's predominantly really where language is. There's some frontal lobe contribution, but essentially when I'm looking at this patient's brain scan, so here's the front of the brain here and the back of the brain here. You can divide the brain into two halves, with this side being the left and the right. This is very subtle. There's maybe a little bit increased black on this left side. As far as the thickness of the temporal cortex is a little bit less compared to the right side. This is something that, again, was read as more generalized atrophy, but in the context of this patient, maybe some meaningful subtle atrophy. I also highlighted when I was going through the scan, there's just a little bit more black on this left than the right, indicating potential parietal lobe at the top of the brain atrophy. Here's those little white spots you see, right? So this is some of this is just wear and tear. Sometimes we call these white spots of aging. So I don't think I've ever seen an MRI over age 70 that doesn't have some amount of vascular disease, but some of this is normal aging. And for her, it's a little bit more than normal aging. So we call it mild to moderate vascular disease, but this isn't enough to account for her symptoms, and it doesn't explain her symptoms. So in this scenario, right, as a more of a specialized clinic, what other tools do we have? Does it make sense to get a PET scan in this case? And so, we've got this sort of history describing potential language issues, pretty normal neuro exam, which we wouldn't expect to find issues in a primary language disorder. Cognitive testing actually matches pretty well with the history. Doesn't always, but does in this case. The MRI is more of a non-diagnostic, right? I wouldn't hang my hat on those subtle changes without further testing. And you'd be supported by that with a normal radiology read, at least not describing specific changes. So we did get a PET scan in this patient, and this is allows us to look at how is the brain working, right? So when I think of that MRI that I just showed you, that allows me to look at the structure of the brain, right? Is there any damage? Is there structural issues with it? Doesn't tell me anything about how the brain's working. So one reason we get this test is, especially if patients can't get an MRI, right? Whether they have a spinal stimulator, they're just way too claustrophobic, they've tried multiple times, or if the MRI was non-diagnostic. the overarching theme of these dementia syndromes or neurodegenerative diseases is that these are brain networks that are failing, and we can see those patterns very well on PET scans. And so that's where this tool comes into use. It is approved for FTD versus AD. Certainly, if you've got a patient with language predominant symptoms, that falls under the umbrella of both FTD and AD, so that would qualify for this, or any behavioral or executive function difficulties, we can get these scans done. Ideally, these are ordered at academic centers with specialists reading them. We see oftentimes they can be misread with less experienced centers, but it's still maybe good to have the images that we can review in some scenarios. This is what her PET scan looked like. So I'll walk you through this a little bit. We're basically looking at the right side of the brain, the left side of the brain, with this being the back and the front, and the front and the back. This is a back view of the brain and the front view of the brain. This is basically everything that's gray here is within normal limits for her age. So this is based on a normative database. And then the more abnormal, it's almost like the weather map that we're going to have out here in the Kansas City area this afternoon, the more red, the more severe things are, right? And so this is showing red changes along the left more than the right. And this is essentially overlying what the language network looks like. This explains her language symptoms quite a bit. And this is actually highly consistent with what we see in like a logopenic primary progressive aphasia. Most of the time, these patients, it's due to Alzheimer's disease proteins. In this specific scenario, one reason was because of potential research studies. We wanted to pursue the spinal fluid, and so did the patients. And basically, you can detect those Alzheimer's biomarkers in the spinal fluid. So we measure both amyloid and tau, which are those two proteins I mentioned earlier. Those can be measured in the spinal fluid. And when there's certain values that when the amyloid actually goes lower and because the plaques are building up and the tau goes higher, then it basically lands within a certain range of consistent or inconsistent with AD. And so for this individual, we can pretty readily say that this is her logopenic primary progressive aphasia or a primary language disorder is secondary to probable Alzheimer's disease. Can start, donepezil, can start some of the treatments we use in Alzheimer's, but also get them involved in a research study if they're interested that is targeting Alzheimer's patients. And so that really highlights a little bit of where this is going as far as a biologic definition of Alzheimer's. This is used on the research side currently, but will be coming to a clinic eventually. And we use it in the clinic, in our clinic. So we think of so if somebody's amyloid negative or positive, you can measure that through a few different scenarios, including spinal fluid, blood, or with an amyloid PET scan. The T is tau, and we can measure that again in a couple different ways. And then the neurodegeneration is really that MRI or FDG-PET scan, or there's a new plasma test called neurofilament light chain that can pick up on that. And then we sort of think of things along a syndromal stage, and then where do they fit on the biomarker stage, right? So you can have patients that have preclinical, they don't have any cognitive symptoms, but they're starting to have all those biomarkers, right? They're the ones that are going to be at the highest risk for potentially converting towards a cognitive impairment stage. This individual, met dementia criteria and had all of these ATN positives, so they fit in this bottom right group. And so I'm just going to quickly highlight a slightly different scenario, right? So if there's a 76-year-old that presents to the clinic with 4 years of progressive memory loss, repeating questions, missing appointments, she's managing most of of her ADLs, but really struggling with the instrumental ones as far as missing medications, paying bills, navigating is more difficult. Her MOCA test is in that sort of mild dementia range, with most of the points being missed on delayed recall, which would match with sort of that amnestic presentation. And say there was an MRI scan done that, did show hippocampal atrophy. That's consistent with sort of that atrophy score that we looked at last week. In that scenario, I don't, that patient doesn't need to be referred to our clinic. The diagnosis is pretty consistent when all these puzzle pieces match up with an amnestic predominant syndrome. The MRI is consistent with an Alzheimer's disease picture. you don't need a PET scan or biomarkers in that scenario. And that's still the vast majority of what you're going to see, right? As far as like, a good 40+% of patients are going to have this type of syndrome, right? There are certainly atypical cases that are much harder to pick up on early on, but this would be an excellent patient for a research referral, right? So especially if they're interested. And so Kelsey will have those rotating slides. And then also there are, certain caregiver stress and support groups that we offer through our cognitive care network team. And there's also the Alzheimer's Association that has some of these. And so that would be a good referral for them as well, but wouldn't necessarily need a referral to our specialized memory clinic. So the last slide, or last two slides here. So the future tools, these FDG-PET scans are really increasing in their ability to recognize patterns. Mayo Clinic's actively working on an AI program that's basically going to really help us recognize these patterns. It's looking very promising. Spinal fluid studies can be done. We do them, I order them about 5 to 10 times a month, kind of depending on specific cases. I don't order any blood-based ones yet. We're using them on the research side. They're being validated. They actually look very good. We just need to hammer out some of the details of, on a population-based study, how much does kidney function influence some of these results? And so we're gonna have to fine-tune some of those to get reasonable cutoffs, but that's gonna be coming, and that's gonna really expand our ability to understand the biology and to be more accurate with what we're calling things. We have been doing some skin biopsies for Parkinson's and Lewy body disease. That's been a more recent test that we've been adding on in cases that are unclear. In the past, I never ordered genetics, but Invitae currently offers a free neurodegenerative genetic panel, roughly 30 to 50 genes, depending on the panel that's chosen. So that's something that's available now. And, we're doing amyloid and tau PET imaging on the research side. Those are both FDA approved. You can order them. It's just insurance won't pay for them right now. That needle will be pushed once there's disease modifying therapies though. And these are going to be important tools. Tau PET actually seems to be the one that predicts cognitive changes over time better than anything else. So that's going to be a reasonable tool in our toolbox as well. Here's a quick picture just showing you, this is sort of a segue into next week. All of these cases that I'm showing you right here, this is 4 different cases. All these are Alzheimer's disease. This is a typical 75-year-old with amnestic memory problems where the temporal lobe, especially the inferior temporal lobe, is affected, versus a similar pattern to what I just showed you today of like a language variant with logopenic aphasia. This is a visual variant where it's really the back part of the brain that's more affected. And these are all FDG-PET scans on the left with tau PET, really just showing that where the tau is where the symptoms are and where the changes are. And then this is somebody with a young onset dysexecutive version of Alzheimer's. So we're a little bit over, so I'm just gonna fly through these. We talked about all of these things. I'm gonna turn it over to Kelsey to rotate a few slides, and then I'll take some questions.